Hi, good morning. I'm just going to give it a minute or so because I can see people are still coming in. Okay, we're about a minute after and our recording has started, so I'll get us going. And I know some folks are just going to continue to come in. Great, well, thank you so much for joining. I'm Janice Ikeda, Director of the Special Projects Team for CSH, coming to you from Eva Beach, Hawaii. I'm excited to welcome you to today's webinar, the second in a two-part series on responding to high acuity challenges in supportive housing. This webinar is co-hosted by CSH and the National Center for Housing and Health. Before we begin, just wanted to mention that the chat video and audio of attendees is disabled. If you raise your hand, we're not going to be able to have people come off mute, so we will just put them back down. Please use the Q&A function for any questions that you have. The slides and a link to the recording will be shared by email with everyone who registered next week at some point. CSH is a national nonprofit and community development financial institution focused on advancing affordable housing aligned with services to help people thrive. The National Center for Housing and Health is a new resource we were excited to share 2 weeks ago that it had just launched. So now it's been a couple of weeks. The center is a new platform focused on advancing the alignment between affordable housing and healthcare. We're doing this by showcasing new and proven approaches, policies, and a resources hub. We have a lot of learning opportunities like this webinar series. We're bringing partners together from housing and healthcare fields, including providers, policymakers, funders, and community leaders. There's a lot to learn and more resources that keep being released, so please check out our website at housinghealthcenter.org and sign up for our mailing list. I know a lot of folks did after the last time, so we should be having stuff coming out soon through there. Now I'm going to jump into the agenda. So like our last session, we're going to start with some quick introductions and just some reminders about the high-level context for the webinar series. Apologies that many of you have heard this before, but in case you weren't here for the first session, we just want to make sure that everyone is aware of the context. Then we're going to dig in with details about the 2 challenges that we didn't focus on during the last session and presentations by a number of partners who are doing really exciting work in these areas. We're going to move on to a panel discussion and then have some time for questions that are submitted by audience members through the Q&A features, and we'll share some reminders about resources we highlighted last session before closing out. I'll move now to introductions. So you'll be hearing from 3 of my CSH colleagues today, including Andrew Spears, a senior program manager on the special projects team based in Philadelphia, Pennsylvania, Katie Bonamasso, the director of our Mountain West team based out of Denver, Colorado, and Teresa Tenori, a senior program manager on our Pacific Northwest team based out of Seattle. We also have my colleague Ariana Saunders with us, who's on our training center team out of Las Vegas, Nevada. Now I'll introduce you to our other speakers. I'm so excited you're going to have the privilege to hear from speakers from 5 speakers from 4 partner organizations today, including Noah Fay, the Senior Director of Housing Programs at DESC in Seattle, Washington, Amy Berg, the Deputy Director of Social Services at St. Nick's Alliance in Brooklyn, New York, Maria Bell, Senior Director, Integrated Care and Housing Services at Pathways to Housing PA in Philadelphia, Pennsylvania. Also at Pathways, Adam Fusero, Clinical Director, and Sarah Gillespie, Interim Vice President Housing and Communities Division at Urban Institute, who's based in the Washington, D.C. area, but will be talking today about work in Denver, Colorado. For the purposes of this webinar series, high acuity is referring to the severity of an individual's physical, mental, and/or behavioral health conditions relative to the amount and intensity of care needed to retain housing and ensure safety for themselves, fellow tenants, and staff. As we shared in the first session, CSH has been hearing from partners across the country in recent years around the interest in finding solutions to help housing and services providers better support tenants with high acuity needs. Based on the questions that we had coming into the webinar in the first session, it sounds like a lot of you are seeing some of these same challenges and themes in your work. Of note is that we're hearing about these challenges in all kinds of supportive housing, including single site, scattered site, in urban, rural, and suburban settings, and with providers serving a variety of populations. So since last summer, the project team from CSH that I introduced that's on this call has been working to learn more about these challenges and promising solutions that providers and communities are working on. So after identifying some of the topics we wanted to learn more about, we conducted a series of focus groups and informational interviews, first internally and then with external partners, including supportive housing providers, national and local organizations working in related systems like respite care, and other partners. We took what we heard and boiled it down to 5 high-level challenges and recommendations, and just keeping in mind that that's from a national perspective. We recapped these in a 2-page summary paper, which was released on the center's website 2 weeks ago, and we used them to shape the webinar series you're participating in now. We're also going to use this information to start planning for some additional activities, including a more in-depth paper coming later and other work to come. Now I'll turn it over to Andrew Spears to start sharing a little more about what we learned.
Awesome. Thank you so much, Janice. Well, these windows out of my way. Responding to folks in the chat. All right, everybody. Hi, Andrew Spears. My pronouns are he, him, his. I'm senior program manager on the special projects team, like Janice mentioned, and I'm gonna get us started off talking a little bit about the challenges that we identified in our focus groups and interviews. So for those who attended part 1 of our webinar, this will be a little bit of a review for you, but we wanted to highlight some things about our process and our findings for folks who might be joining us for the first time today before really diving into the content. Move this window over. There we go. Okay. A quick note on language, I just want to highlight, our team has really made a conscious effort to not to refer to individuals as high acuity individuals. We know that people who are living in supportive housing might struggle with high acuity challenges intermittently, but we want to be using person-centered language and avoiding labeling and stigmatizing whenever possible. Just recognizing that folks move in and out of managing high acuity challenges. So as Janice mentioned, our project team conducted extensive research through interviews with providers and communities who are grappling with high acuity challenges all over the country. We held multiple internal focus groups and informational interviews with other CSHers before hosting several external focus groups that brought together experts from 10 different agencies. And out of these conversations, these 5 key themes emerged. So the first major challenge that providers noted was just identifying the population of the people considered to meet the definition of high acuity. In our interviews, providers stated that anywhere between 5% and 100% of the tenants that they were working with were struggling with high acuity challenges. But after synthesizing our notes and digging in a bit more, we've come up with an estimate that roughly 5 to 10% of people in supportive housing might meet the definition of high acuity at any given time, right? So we want to really emphasize this population is not static because tenant needs change. And we often see individuals who are moving in and out of high acuity. So someone who might be experiencing high acuity concerns now can certainly stabilize and fall out of the high acuity category later. And then conversely, we know that individuals can experience lapses in sobriety or an uptick in mental health symptoms or declining physical health, meaning tenants who are previously stable can cycle into the higher acuity category. In our last webinar, Rachel Wilson of Housing Forward in Dallas, Texas, shared about her organization's work to identify those most in need of complex care supports and how they were leveraging cross-sector partnerships through twice weekly case conferences to respond to the changing needs of individuals in their system. The second major challenge that providers identified was meeting the needs of tenants with significant medical concerns or difficulties with activities of daily living or ADLs. Things like cooking, cleaning, maintaining personal hygiene. Programs are often not staffed robustly enough, nor are staff adequately trained to address medical or ADL challenges a lot of the time. And we know that tasks like teaching someone how to store their food properly or do their laundry or keep their unit tidy can take hours, if not an entire day. And most case managers or service providers just don't have enough time to devote to this intensive level of support. Additionally, meeting the needs of tenants with significant mobility challenges or deteriorating physical health can strain staff resources. Simultaneously, most skilled nursing facilities or nursing homes lack the ability to manage behavioral health conditions. So, in last month's webinar, we heard from Dr. Alexis Chetiar of Cardea Health, who talked about Project Room Key, which is a pilot in Alameda County that successfully housed thousands of unsheltered individuals with complex chronic illness and behavioral health conditions. The third challenge that we identified in our conversations with providers were shifts in the workforce over the past few years, particularly in response to the COVID-19 pandemic. So, providers are reporting higher rates of turnover among staff, noting that a lot of time can be invested into onboarding and training just for that person to leave soon after they've gotten fully up to speed. In other instances, providers note an inability to adequately train staff as they're onboarded due to time and budget constraints. They need case managers out in the field seeing clients rather than sitting through weeks of training and shadowing. But this means that supportive housing tenants aren't always interacting with the most skilled or seasoned workers. This obviously impacts the workers' ability to adequately respond to some of the higher acuity needs of tenants. In one interview, a provider stated that they're seeing some of their least skilled workers interacting with their tenants with the most complex needs. And as you can imagine, this is not producing ideal outcomes. We were fortunate to have David Langle Martin of Park Center in Nashville join us last month to share about two promising practices to respond to this challenge. The first, pairing service coordinators, case managers with certified peer recovery specialists to enhance services using their complementary skill sets, and then also engaging a local MCO in an innovative partnership that reduces caseload size and provides a per diem rate that supports high intensity care. So again, these first three challenges were covered at length in part one of our webinar series, which if you missed it, will be available on the center's website soon. And then the fourth and fifth challenges that providers identified really go hand in hand, and we'll talk about them today. Next slide. Before I turn things over to my colleague Teresa, I'll say we heard from almost every single person we talked to in our focus groups that in our interviews, they shared about the challenge of working with tenants who exhibit behaviors that impact safety, their own safety, the safety of staff, other clients, other tenants, or others in the community. These are things like violence, hoarding, and fire setting. We know that responding to these behaviors take a heavy toll on both program staff and resources. It's time consuming. There are often no easy answers, and responding to safety concerns significantly contributes to burnout among staff and can lead to high rates of turnover. It can also be incredibly difficult for programs to mitigate safety concerns in scattered site settings. Similarly, providers also discussed the ongoing challenge of meeting the needs of tenants with chaotic substance use and severe mental illness, particularly when that includes psychotic disorders. So, working with co occurring disorders has always been part of our work in supportive housing, but providers are noting that the ways that changes to the drug supply seem to really impact behaviors associated with substance use and mental illness. Much like challenges related to safety, these behaviors continue to contribute to moral injury, compassion fatigue, and burnout among staff. So those are our five major challenges. That's not to say that there weren't plenty more difficulties providers were experiencing, but across the board, those were the most common, or other challenges we heard about seem to be related to or could kind of fall under these broader umbrella categories. We also want to recognize that supportive housing looks different across the country and that these challenges will look different for different programs in different settings. So what's challenging in single site or congregate housing might look different in scattered site or with a different population or in different areas of the country. So we hope that these resonate with you. We also want to hear from you about other trends you're seeing in your work, so please utilize the Q&A function to chime in with questions. And don't forget to fill out our post-session survey to let us know about challenges you're encountering in your community and what innovations you're seeing in response. So we're excited now to turn things over to our presenters who are going to share about some of the incredible work they've done to respond to challenges with safety, mental health, and substance use in supportive housing. I'll turn it over to Teresa to introduce our first topic and our two presenters.
Thank you, Andrew. Hopefully everybody can hear me. And welcome, everyone. Thank you for taking time to join us today. Yes, so now we're going to really take a deep look at behaviors, behaviors that really impact safety, and let you know what we heard and some recommendations, and then I'll turn it over to our colleagues. So we heard from providers that high acuity behaviors definitely impact safety. As Andrew said, there's a number of types of behaviors we heard about. Providers repeatedly describe tenants with high acuity behaviors struggling with this chronic emotional and behavioral instability, including things like rapid escalation around routine interactions, behaviors such as yelling, threatening language, hostile sometimes. That these behaviors are challenging and really impact staffing and resources, which are the other challenges. It's really hard as we looked at these challenges to come up with just one and then to realize that these are interwoven sometimes and overlap. The safety concerns emerged as really almost a defining feature of high acuity. Safety of other tenants, safety of staff. We heard about physical alterations between residents, threats with neighbors and staff. A lot of housing providers emphasize that even isolated residents with these kinds of behaviors can destabilize kind of a whole entire building at times, especially when staff lack maybe authority or any backup to respond. They often talked about these residents that meet this high acuity challenge, described as kind of cycling through hospitalization, detox, involuntary holds, and then returning to housing without real meaningful behavior change. And then they can re-enter this crisis situation. So it leaves housing staff really functioning as a kind of a crisis managers. And sometimes staff have those clinical skills to do that, and sometimes they don't. The providers also consistently reported difficulty managing things like guest policy violations, severe unit deterioration between the hoarding, maybe biohazards, infestations that occur. Also, just residents and tenants who would refuse kind of following basic safety expectations. And I want to emphasize that these aren't maybe single violations, but more of a persistent non-compliance. So it's not just happens once, but it happens often. Let's see what else. Also across many focus groups, we heard about tenants with high acuity challenges declining and not engaging in services. Or maybe they engage in a limited way and don't stick with the treatment. Oftentimes, this is created because they have a very deep distrust of systems and providers. But this really has kind of held some core tension in our field that around treatment and housing. So this persistence can really help us talk about treatment and how to help tenants. So the recommendation we're talking about here is really around a couple things: the training and skill building of staff, but also looking at different levels of services within housing, which I think is a really important part of. It's not everybody in supportive housing, again, needs high level services, but offering these levels of services can be really helpful. We're also going to hear from our guest speakers today around some of this mobile crisis response that can be available to local systems, which is very helpful. So I'm really pleased to introduce the next two speakers. One, Noah. Noah's from my community in Seattle, from DESC, also known as the Downtown Emergency Services Center, but DESC is more famously known as. And then Amy Berg, who is as was stated earlier, the Deputy Executive Director of Social Services at St. Nick's Alliance in Brooklyn, New York, who's going to talk more about scattered sites and responding to these behaviors there. So continue to settle in with us, everyone. While we know there's many of you out there doing some amazing work, these two, Noah and Amy, have so much to share with us. I'm really pleased that they're with us. So Noah's going to start us off, and then Amy, please join in after Noah's last slide. So thanks, everyone.
Hi, good morning, everybody. It's so nice to be here with you all today. As Teresa said, my name's Noah Fay. I'm the Senior Director of Housing Programs in Seattle. We can jump to the next slide. All of this looks and sounds very familiar for the water that we're swimming in permanent supportive housing. I'm coming at this primarily from a lens of site-based permanent supportive housing, but not exclusively at all. Our portfolio is heavily site-based permanent supportive housing, but there is a sizable scattered site portfolio and deep connection with outpatient behavioral health services. Is the lens I bring to this. Our focus with DESC at DESC is really exclusively single adults with really profound disabling conditions with a primary focus on serious mental illness and co-occurring disorders being who we want to serve and overwhelmingly serve across our portfolio. So these issues are near and dear to my heart. And where I want to take us is just one plank of strategies to address the issues that CSH has done a great job of identifying, primarily focusing on the increase in behavioral health crisis. The slide that you're looking at right now is a reflection on some of the things we really noticed coming out of the depths of the pandemic. Overdose risk, substance use harms and challenges, behavioral health crisis, living conditions, unit conditions are always a key area of focus for permanent supportive housing at DESC. But the impacts of all the COVID-related changes to our society were pretty profoundly impactful around these three areas. And so just want to acknowledge that these other things all are largely interrelated, but today I'm going to talk about our response to behavioral health crisis and what came next. So if we go to the next slide. So we found ourselves here a little bit in the water swimming, and I want to give some context to not just describe the intervention, but how it came about. Because each community is different, but a lot of these kind of dynamics exist. And so I would be remiss if I just talked about the resource and didn't talk about the context by which it arose. And so we were discovering and talking about internally, externally, just the impact on tenants of all the way supports had changed during the pandemic. We explicitly limited the amount of in-person visits people were having to people's apartments out of an effort to promote social distancing and following public health guidance. And this model, high quality PSH, is highly interventionist and highly assertive. And so we took away kind of the key foundational component to our work. We were still seeing people and engaging with folks, but not to the degree we were before. And so isolation started to increase, less communal events, almost no communal events for quite a while, of course. And then the amount of natural supports in the community really deteriorated. So people were more on an island and more isolated than ever before, which was exacerbating things for everyone across society, but particularly folks living with some of these profound behavioral health conditions. We saw people deteriorate. The key piece, though, simultaneously to this all happening, our local crisis system, so the involuntary treatment system, other resources in our community were deteriorating for a variety of reasons. Workforce issues, some adjustments in legislation that created some workforce challenges, workflow issues, capacity for people to access crisis care. really was dramatically reduced in our community. So what we were seeing is just a substantial rise in individual level deterioration, and that impact not just for the individual, but for the community as a whole. I think Teresa made reference to this, is that what we were seeing, for example, would be somebody having a psychiatric crisis in a program where prior to some of these deteriorations that were parallel with the COVID pandemic, support could be brought to bear in a relatively short amount of time that was modestly effective most of the time, meaning people were able to get the help they needed in a day, 2 days, get access to broader care that, isn't always effective. Hospitalizations are not obviously the answer for everything and something we try to avoid, but is a dynamic in the work we do. And that was a resource that people were able to access and were able to get some support. Those resources didn't go away, but they became less accessible to people, meaning those crises were playing out in the community, not in a setting where people could get more support. And so that was having downstream effects on other neighbors, on the broader community, on our staff. So I think someone made the comment that housing case managers, housing support staff ended up kind of being the catch-all for all of these issues, whereas they are always central in managing these sorts of issues in PSH, but usually there were supports in place that were modestly effective. Those largely went away. So if we jump to the next slide, we found ourselves in our community needing to call attention to that. Central to the success of PSH is the ability to increase the amount of needs folks need. And so this dynamic about the increase in high acuity needs in our community, we were hearing left and right. And there was a lot of demand from other providers, from other sectors on finding ways to invest in maybe more coercive approaches, find ways to make it easier for people to be evicted from housing programs because of these issues. And we realize that is a terrible approach to respond to people's behavioral health care needs, and wanted to call out that there's not, from our perspective, an increase in high acuity. I love, Andrew, your comment about not labeling people this way. There's not an increase in the amount of high acuity people in our population, which was a talk. People had like the population of PSH has changed. I reject that notion. I don't think that's true at all. I think the systems that support people with high needs in PSH has become less accessible and less responsive to their needs. Not an issue about folks themselves. So we need to change that system and find a way to make that system respond to what their needs are. And in the peak of a pandemic, that was damn hard. So a few things that we did is we led with our behavioral health peers in the community to call to attention that our crisis system in our community, for which all people need access to, particularly folks who live with some of the challenges that our population does, they need access to it. And so there's community advocacy with lots of key stakeholders, including elected officials. Long story that I won't get into but fundamentally led to a ballot measure. They got a levy on the ballot that passed to invest heavily in deepening a crisis care system in our community, which is fantastic. Some of the results indirectly and directly of that was a deepening of investments into the resources in PSH or that serve PSH in particular. So what was great about this was, while it was a broadening and deepening of crisis resources in our community, it invested explicitly, at least in a portion, to PSH in particular, recognizing that that is a population that is likely disproportionately going to need these sorts of resources. So we should dedicate specific resources to them where appropriate. And that's what you see on the screen. A couple additional roles that we've been able to deploy across our portfolio and sustain, roles that are designed to provide added support when somebody is potentially in a situation where their housing's in jeopardy, to add added resource to the existing care team that can be deployed in a pretty fluid way. Another role that is deployable around a variety of different programs, particularly in the evening hours, where evening and night staff are disproportionately burdened by some of these issues with less resource than the other shifts, of course, can provide just general engagement support to try to head off crisis before it starts. So to be available in the space, to have more general de-escalation support, that's been really valuable to have. But I think most notably, what came out of this advocacy and this levy was a dedicated mobile crisis team to the continuum of PSH in our community. So whereas prior to this team, a PSH program or staff in a program was working with somebody and they were slipping into psychiatric crisis, behavioral health crisis, The resources available to them beyond the existing PSH and the existing care team were law enforcement, if we thought there's a crime or a public safety issue, or the ITA involuntary treatment system, which was either not responsive or overly restrictive or not appropriate or not as accessible, meaning a lot of folks, one, didn't get the help they need. The help they did get often was not really tailored to what they needed. It was just what was available. And this team was stood up to be a dedicated resource to PSH providers. So PSH and only PSH had the ability to call and say, we're dealing with somebody who we're worried about is slipping into behavioral health crisis. Can you deploy to our sites? And they deployed. We never quite got to 24/7, but we got pretty broad coverage to deploy to that program to do two things. There is immediate crisis response. So the idea was to respond within 30 minutes, and more or less that was doable, to provide added crisis response. So these were folks that were highly trained in de-escalation. All our staff are, but this was really their specialty. It's a multidisciplinary team, so it came with medical support, which was invaluable to be able to provide acute, immediate medical interventions for folks. Often found folks are more receptive to medical intervention in a crisis as opposed to behavioral health interventions. Not to draw a false distinction between those two, but like primary care responses in a crisis, people received pretty well. And then this team also had the ability to follow people for several weeks after, and an ability to see what kind of services somebody needs to connect with or reconnect with. Found often that almost invariably these folks were at one point or still connected to behavioral health resources, but that had slipped and wasn't as a close a connection as before. And this team was meant to be an added resource to not just stabilize that acute crisis, but provide ongoing connection or provide short-term support to make sure there's an ongoing connection after that resource went away. If we jump to the next slide, I love seeing all the thumbs up and the hearts. I've got sad news that we've not been able to sustain that model that way in our community. So didn't want to bait and switch you all, but we haven't given up on it. There's still work happening in order to keep that resource alive and well. The ability to remain a dedicated resource to PSH has been hard. So we've been working closely with our broader county to find a way to ensure our PSH programs still have that dedicated crisis response through a larger crisis continuum resource in our community that's meant to serve the community as a whole, giving PSH some dedicated pathway, kind of like a lot of crisis programs provide dedicated pathways to first responders. We made the case that PSH really should be considered along those lines and let us get to the front of the line, given that if we're calling, it's probably because we've already triaged the issue and we could use some attention. That is working well. We're still adjusting to all of that. It does leave the gap, though, on what do we do for folks who obviously still have profound behavioral health issues, and the larger behavioral health system is not designed in a way to absorb them into their care, whether simply the way the intake process is structured is just too rigorous for somebody with the level of conditions they're dealing with, to more often than not, people lack the insight. If the behavioral health issue is significant enough, often folks don't see the need or aren't interested in engaging in care, yet dealing with pretty profound symptoms. So we're looking to evolve this team, and we're designing something right now for a launch later this year, which I'm really excited about, to do kind of psychiatric PSH-based outreach to try to draw into care people who are profoundly disabled by mental health, primarily issues, who for otherwise obviously would qualify based on symptomology into behavioral health resources. But because of the way those symptoms manifest, they're unable to access them. We want to design a team that accommodates to those needs to provide not forever care, but not in short-term care either, to outreach and engage those folks into care to avoid them otherwise falling into the crisis system, the jail system, and what have you. And that is something that our county is working with us on. Jury's out on how that all shape up, but we're really excited to be able to deliver that highly flexible PSH-focused care moving forward. And we're expecting to see some of the results that we saw with these other teams, like less of a need to engage with 911, more support for our staff working off shifts. They are often the group that needs it the most, so we can help people stay housed and just do better. So a lot to work on there. Really excited and happy to answer questions later today. And I think, Amy, it's my job to hand off to you next.
Hi, everybody. I'm really happy to be here can you give me to talk about our pilot program integrating a mobile response team within our scatter site supportive housing program? I'm Amy Berg, and I oversee all the social services here at St. Nick's Alliance. You can go to the next slide. This is just what I'm going to talk about today. I'm going to give you an overview of our organization. I'm going to talk about the challenges that led to our pilot proposal. I'm going to talk about our underlying philosophy and the workflows that we developed. And I'm going to give you some idea of the outcomes that we hope to see and our progress to date. You can go to the next slide. So St. Nick's Alliance is a community development organization. It's located in North Brooklyn, New York, and we serve over 18,000 people a year. Our mission is to transform the lives of low and moderate income people through four essential areas, which is youth and education, affordable housing, workforce development, and elder care. The Scatter Site Supportive Housing Program, which I'm going to talk about today, we house 536 formerly homeless households, both individuals and families who live across Brooklyn, Manhattan, and the Bronx. Unlike congregate housing, this program provides independent apartments, and it requires the staff to manage both the clinical and social service needs as well as the residential requirements. Our program organizes the work into four different case management pods that's each led by a licensed clinician, and the goals are to ensure that the households are stable and attain the highest possible quality of life in the community. You can go to the next slide. This slide shows some of the challenges that we've been discussing that we also faced in our program. The people that we serve have complex medical, behavioral health, and substance abuse needs. And as you can see, we have, vast majority have some kind of chronic health issue exacerbated by previous experience in the shelter system and all kinds of other trauma. 14% are not engaged in consistent health care, even though generally we do a very good job of making sure that people stay in relationships with their primary care providers. 58% who have a medical diagnosis are not participating in behavioral health treatment. We also have tenants who are aging in place, which is quite well known that that's happening across the board in supportive housing, and they're demonstrating diminished ability to care for themselves and their environment. And also sometimes they're resistant to accepting support. Our standard caseload levels limit the ability of staff to adequately support these clients with greatest needs. And this lack of capacity contributes to our staff stress and to burnout. People were feeling like they weren't really able to give the level of support necessary to prevent poor client outcomes and to maintain housing stability. We recently started a new contract, and when we saw the challenges with this program, which was for people whose primary concern was a mental health diagnosis or active substance abuse, we started to focus on how we could stabilize this new group of tenants who seem to have more complex problems and less experience and skills with living independently. Next slide. So now I'm going to show three examples of some of the types of tenants that we work with who we think meet the criteria for high acuity. These are actual pictures of the homes of these tenants and a description of the barriers they faced and the interventions that our staff tried. So this is WM. This is a tenant who's aging in place and having difficulty caring for herself. To boost engagement, the program tried assigning different case managers and peer specialists because she wasn't engaging well. They were able to leverage the relationship that she had with a maintenance staff that she trusted. She agreed to go to a rehabilitation center to get stronger and to develop her skills to take care of herself. And right now we're working on a discharge plan that includes home care. Next slide. ABW, these are pictures of this tenant's second apartment in supportive housing. Here, the staff utilized their access to multiple rental units to relocate this tenant when their previous living environment became unsafe. But as you can see, this was not an effective solution. We continue to work with this tenant to develop trust and to prioritize basic safety standards like maintaining emergency egress and sanitary living conditions to reduce the complaints from the neighbors. Next slide. This is a tenant who engaged really well with the staff. And despite a huge effort by the entire team, he ended up losing his apartment. Unable to engage this tenant in ongoing treatment, his psychosis got worse and he started setting fires in his unit. This was really disappointing to the staff. And that was kind of part of what got us thinking about how we could prevent loss of housing for similar tenants. We came up with the idea of an internal mobile response team. And then we were thrilled when we saw that CSH was looking to fund pilot projects that utilized innovative ideas to keep high-need tenants in supportive housing. Next slide. So the way we developed our model was guided by these 5 key principles. We wanted to have an open referral process because we wanted any staff member, including like maintenance or an administrative person, to be able to refer to the program. It's a mobile medical and social services program, meaning that we see tenants directly in their homes and we serve them literally where they're at. The program was designed to be an integrated short-term support model that coordinates with the existing case management to help the tenants achieve stability, engagement with community resources before transitioning back to their primary team. We wanted to have an interdisciplinary approach so that the staff had the skills and the knowledge to address complex needs. So in addition to a licensed social worker who is the team lead, we brought in a nurse, a substance abuse specialist, a peer specialist, and a case manager. The wellness outreach team was trying to improve success rates by facilitating referrals to community resources. So this is a very time-consuming process to make sure it goes well. So they are prepared to do warm handoffs, providing for scheduling, escorting, and ensuring tenants through the whole engagement process with medical and behavioral health appointments. Next slide. So this pilot is supported by a 2-year grant from the Corporation for Supportive Housing and the Helmsley Foundation. And it incorporates a structured workflow, which gives us the ability to track who we serve, the methods used, and the outcomes. The goal is to understand the efficacy of the wellness outreach team model so that it could possibly be replicated and implemented more widely. So the operational design involves a brief initial assessment to determine if the referred person is eligible. And then we will prioritize those that are eligible so that we have about 40 tenants enrolled as active members at any given time. Others with less priorities are being placed on a waiting list. We felt like 40 was the number we could serve at any one time. Following acceptance into the program, tenants receive a comprehensive in-home assessment and work with the team to develop a collaborative support plan. And then home visit frequency, which could range from weekly to monthly, depends on the needs of the tenant. And that means that different members of the team could be part of that visit. So if it's somebody who has, primarily a health condition, the nurse as well as the case manager would be there. Someone who has substance use concerns, we would be sending our CASAC or substance abuse specialist. We maintain clinical coordination by having weekly meetings throughout the year, and then we will also be inviting the existing case manager. Progress will be monitored through quarterly functional assessments. Once the tenant has achieved stability and hopefully connected to a community resource, because we can never predict how that's going to work, we will transition them back to their standard case management. Next slide. So when we developed this project, we created a logic model that helped us develop specific goals for the enrolled tenants to establish positive outcomes. So that's what you see here. These included housing retention, social service engagement, crisis reduction, such as like visits to the emergency room or hospitalizations, physical and emotional stability, and improved ability to care for themselves and their homes, as well as acceptance of in-home support such as home care. So some examples of those more specific SMART goals might be 60% of tenants with an identified medical concern will access primary health care, or 30% of tenants with a high-risk substance use will agree to a harm reduction goal. So I wish I could give you some actual outcomes, but we're really only 4 months into this pilot. And so far, we're doing well. We've got the team, the interdisciplinary team. We've developed our workflow, our logic model, and we've designed and put all of the documentation and our assessment forms into our database. We opened up the wellness outreach team to referrals from all the staff, and so far we've gotten 60 referrals, which is what we predicted because we knew there was a lot of high acuity, high need tenants out there in our program. Currently, the team is assessing the referrals to prioritize our first 20 clients. And they started having their clinical meetings, and probably in the next week or following week, they will be starting to make their first home visits. So I hope that maybe I'll be able to come back at some point in 6 months, a year, to actually report what our outcomes are. I want to thank you all for the opportunity to present our wellness outreach team pilot. I hope that our ideas stimulate other programs to try different solutions for helping these challenging tenants to remain in supportive housing. Thank you.
Thanks so much, Amy. Thank you to Noah, Amy, and Teresa. I want to transition us to our second set of presenters now. We're going to spend some time talking about the challenges presented by substance use and severe mental illness. This was possibly the most commonly highlighted challenge throughout all of our focus groups and interviews. Like I said, while we know that individuals managing behavioral health conditions have always been a part of our work in supportive housing, providers are noting that things like longer unsheltered periods, individuals living with serious mental illness for 20 plus years longer than in the 1990s, as well as sharp shifts in the drug supply, especially fentanyl and methamphetamine, with xylazine emerging in certain markets. These things are causing increased strain on our resources and staff. Providers also report that polysubstance use has led to more overdoses, prolonged withdrawal timelines, and more challenges with psychosis, particularly meth-associated sustained psychosis. And complex stabilization needs are more common, with xylazine bringing severe wounds and agitation during detox. In response to all of this, training and skill building around mental health first aid, psychosis, and other related topics is strongly recommended. Beyond that, providers are looking to enhance their substance use treatment services, focusing on overdose prevention and medication-assisted treatment or medications for opioid use disorder. Contingency management pilots, incentive-based SUD interventions are being tried with some promising engagement signals. One example of which our presenters Maria Bell and Adam Fusaro from Pathways to Housing PA will share about, in addition to the unique staff supports and partnerships leveraged to meet the needs of individuals with opioid use disorder. Following their presentation, we'll hear from Sarah Gillespie from the Urban Institute, who has been leading the randomized control trial study of Denver's Housing to Health program, a pay for success program that serves 125 frequent users of emergency services in Denver with significant substance use needs. Sarah will be sharing the perspective of how we use data to identify the needs of a population and then modify our programs to meet the needs of tenants based on data. So let's go to the next slide and I'll turn it over to Maria and Adam to get us started. Thanks so much for being here.
All right, is the slide set? Okay. Hello, good afternoon, everyone. My name is Adam Fusero. I'm the clinical director at Pathways to Housing. I've been part of the organization at Pathways to Housing PA since early development in 2008. And before discussing our main contribution to today's presentation, which is our long-acting injectable incentive program, I'd like to briefly share who we are as an organization. Pathways to Housing is a housing first organization based in Philadelphia. Many of you may already be familiar with the Housing First model, which is a strong evidence-based approach designed to end homelessness by providing immediate access to permanent independent housing without preconditions. Our work is person-centered and grounded in harm reduction and supported by intensive case management services that help formerly homeless individuals improve their stability, health, and quality of life. For the first 9 years at Pathways to Housing, the primary diagnosis of individuals that came into our program was serious mental illness. However, as Philadelphia experienced the rise in fatal overdoses driven by fentanyl in the community, as you all experienced, the city of Philadelphia asked us to expand our intervention to include individuals with primary diagnosis of an opioid use disorder. At that time, also, the state of Pennsylvania was developing a response to the overdose crisis through the creation of what's called the Center of Excellence, and we call that the COE, which probably all COEs call it. COEs focus on outreach, treatment engagement, and care coordination for individuals with opioid use disorder in community-based settings. You can switch the slide. Actually, it probably should have been on that slide, the next slide, the whole time. I'll just let it sit there for a little bit, and then you can switch to the next slide. The COE model was a natural fit for us. We approached it differently than many other COEs across the state. Rather than operating independently, we've developed a triad partnership with Project Home and Prevention Point in Philadelphia. Each organization brought us specialized expertise that strengthened our collaborative response to the opioid crisis. Project Home operates a federally qualified health center, so an FQHC, which we created a satellite location in our office, which was the basis for our incentive program and our support for individuals with opioid use disorder. Sorry. I just lost my place on my notes. So at the same time, the Pennsylvania was developing a response. Okay, so the COE. So the COE was a natural fit for us. Project Home has a satellite site on site, and behavioral health services and our MAT program was conducted out of that. Prevention Point has been a long leader in Philadelphia in outreach and harm reduction services. People who use opioids in Philadelphia, particularly within the Kensington area of Philadelphia, where the opioid epidemic has been devastating to the community. All right, you can switch to the next slide. So the COE has allowed us to expand our treatment support while remaining grounded in our harm reduction services and participant choice. The team consists of a program manager and 4 MAT care managers, and a program assistant who supports coordination of our reporting to our funders. Importantly, this is not an office-based program in the same way of our case management support to people that have opioid use disorder, it is also a community-based intervention. Our COE team conducts home visits and does street outreach throughout the community, spending significant time building relationships, reducing barriers, and connecting individuals to treatment. The COE is funded through Medicaid, so a per member per month model, and oversight of the COE has been given from the state to the counties in Pennsylvania. So our funder for the COE is CBH in Philadelphia. So this slide highlights our goals of the COE model is an engagement and retention in care, housing stability, treatment linkage, and integrated healthcare. When participants express readiness for treatment, the COE helps coordinate linkage to inpatient treatment, detox, and MAT services, while also completing ASAM assessments to determine an appropriate level of care. Our program remains trauma-informed, harm reduction focused, and while also recognizing that participant choice is integral to engagement. Adding this COE support to the case management team that we provide, the wraparound services, has provided us what we've known all along when working with people with mental illness, that housing, healthcare, harm reduction, and treatment engagement cannot operate separately from the population we serve. It has to be integrated. And so Maria is going to talk about a solution to a problem that we saw within the population, which highlights the need to be flexible and responsive when developing interventions.
Hey, thank you, Adam. And you can go to the next slide. So as Adam said, my name is Maria. I am the Senior Director of Integrated Care and Housing here at Pathways to Housing. So I oversee all of our clinical teams. I oversee the COE. I oversee our psychiatric services, our community inclusion department as well. I've been at Pathways to Housing less than a year, maybe about 7 months now. So I'm relatively new in the Pathways world, but I've been familiar with Pathways since they first came out in 2008. So that's just a little bit about me. So to continue on, with the work that our COE team was doing, we saw that housing stability was a big issue. We were experiencing high maintenance costs due to damages in units. We saw people flushing needles down toilets, which caused very expensive plumbing issues. People were kicking in their front doors because they couldn't find their keys. There were holes in walls. All kinds of damage was done in units. So we definitely experienced high maintenance costs. We were receiving a lot of nuisance calls from other tenants, from landlords, property managers, due to the behaviors of our participants and their guests. One thing that we saw was minimal engagement with psychiatric care or medical care. People weren't, going to psychiatrists or therapists. They didn't have primary care doctors that they were working with. And another thing as well was there was a lack of financial stability, which these are just some of the things that we saw that led folks to being at risk for eviction. So we thought we were trying to come up with different ways. How can we address this? What can we do to help people become more stable in their housing? And at the same time as we were having those conversations is when the long-acting injectables hit the market. So Sublocade came out. And we saw this as an opportunity. So we turned this clinical opportunity into a participant-centered pilot program with Sublocade. So in that, people that participated in the pilot were put on Sublocade. They started taking Sublocade. They would come into our office, go to the clinic. They would get their monthly injections. They would receive incentives for coming in, getting the injection, and as well as completing surveys. They would engage with the MAT case managers at least 2 times a month, work on their recovery goals. And we were able to see some good outcomes through that. So we had about 24% of the pilot participants asked if we could move them to a different neighborhood because they realized that the neighborhood that they were currently living in wasn't conducive to their recovery. We had 8% of individuals that had were at house risk for eviction when we started this, that were able then to get things right and maintain their housing. We had 44% of the participants apply for Social Security. 84% of individuals starting engaging in psychiatric services and behavioral health services. 96% started, connected with a primary care. And I think that had also a lot to do with the partnership with Project Home and having the integrated care clinic on site at our offices where they could get primary care services. And then we had 16% of individuals either engaged in some type of vocational support services or were able to get successful employment on their own. Next slide. So we were really excited about that. But one of the things that came up throughout this process was there was a change in the drug supply in Philadelphia. So Philadelphia had a big impact. Well, I'm sorry, we were impacted a lot by the opioid epidemic, and fentanyl was, being laced into pretty much any drug that people were taking, and a new drug hit the street called medetomidine. It is a sedative that is used by veterinarians. The street name for it is rhinotrank. It impacts the cardiovascular, respiratory, and nervous system. Unfortunately, whether it's Sublocade, whether it's methadone, Suboxone, none of those MATs have any impact on medetomidine, as it's a different class of medication. So we saw, not even just within our Pathways participants, but just the general public in Philadelphia, people were dying left and right. The way the drug works, when you are high, the high lasts for about 2 hours. During that 2 hours, your vitals drop dangerously low. Once you hit the 3rd hour, you go into withdrawal. And when you're in your withdrawal, your vitals shoot sky high. People were going into detox thinking, or presenting to inpatient for treatment because of what they were experiencing. They were being admitted into treatment, and people were dying in treatment centers. And what we realized is this is not it's not a drug treatment issue. It's a medical issue. So one of our initial goals of this pilot program was to decrease hospitalizations, to, decrease the need to go to detox, to decrease the need to go to inpatient rehab or using emergency rooms as a way to get to those places. But we actually had to recalibrate with this new drug that was on the street and encourage people, go to the emergency room, go to the hospital. And unfortunately with this, the hospital can't treat you until you're actually in withdrawal. So we've had some participants tell us that they're scared. They won't stop using because they're afraid as soon as they hit that withdrawal mark, then they're going to die. It's been scary. And we had to adjust and say, hey, no, go to the hospital, let them know what your symptoms are. They'll take your vitals and take you right back. So we had to change our priorities throughout this pilot to make sure that, people were okay and that they weren't dying because of the change in drugs on the street. Next slide. So with the emergence of medetomidine, it doesn't mean that MAT isn't useful. It doesn't mean that the COE model is not useful and that we should just throw it all away, right? So what do? We keep what's working. So here as an organization, we continue to provide access to MAT and MOUD. We continue to practice harm reduction because, as we know, trust, flexibility, and choice are really what what keep people engaged. We work to establish acute care pathways as right now the drug supply is requiring medical interventions. And lastly, we stay focused on housing stability because a lot of times clinical instability often shows up as tenancy crisis, apartment damage, and people being at risk for eviction. So what we have found is that the COE model works because it's flexible. The housing first gives the stability, harm reduction. It keeps people engaged and engaged in the services, and the MOUD supports really help people with their recovery. And we want to make sure that we're staying as flexible as possible, as we know, recovery is not linear. Every path is different. So that requires us to be flexible just in general, while doing this work. And next slide. I think that's it. Yes. And I'm sure we'll be taking questions later on.
Amazing. Thank you both so much. Let me turn it over to Sarah to keep us moving.
Hello. Thank you. So I'm Sarah Gillespie from the Urban Institute. We're a nonprofit research organization, and we are the evaluator for the Housing to Health Supportive Housing Program in Denver, which is a partnership of a lot of organizations who are doing the hard work in Denver: Colorado Coalition for the Homeless, Well Power, Denver Health, CSH, all part of this really great partnership. And so what I'm going to talk about today is how we use some data to help these partners understand what were the high acuity needs of residents in the PSH program. So if you want to go to the next slide, this was set up as a randomized controlled trial, which meant if you met the criteria, you were eligible for the program. And we used pretty similar criteria to an older supportive housing program that had run from 2016 to 2020. And so kind of expected to see similar types of participants enrolling in this new supportive housing program. But pretty soon, pretty early in the program, the providers were saying, this feels different. These needs feel a lot more acute. We need, what is going on? Why does this feel so different? And so that's when we started to look at the data. And what you see here is from Medicaid claims, diagnoses at baseline. So when participants came into the program, 94% had a substance use disorder, 80% had a mental health condition. We assume also these are probably conservative because these are among people who had received some sort of service in order to get the diagnosis to show up in the data. So pretty much everyone had a lot of unmet healthcare needs at baseline. I think another thing that surprised some of the partners, 42% of folks had a diagnosed brain injury. You can see the ones for wounds and poisonings, which include overdoses. So just across the board on these diagnoses, a really high healthcare needs at the beginning of the program. On the next slide, we were also able to look at what types of healthcare services people had been getting before they entered the program. Pretty much everyone had been using the emergency department, an average of 33 ED visits prior to entering the program. But then on some of the types of services we want people to connect to, like primary care and outpatient care, more around like half the population was accessing that type of care. So this just was another sign that people were utilizing that emergency care, but there was still room to connect people to the types of services they needed. On the next slide, I think the other thing that was really happening is that the providers were raising this flag that the substance use was different. Oh no, this slide is not showing up quite right on my screen, but the substance use felt a lot different, and the rate of mortality felt just a lot more than what they had experienced in 2016 to 2020 with what we thought was a similar population. So I don't think the data is showing up quite right here, but if you could see it, and I can maybe put a screenshot somewhere, we have 10 years of data on mortality and the cause of mortality. And this was for the entire population eligible for the program, like not related to who was in the program or not. But if you were eligible for the program, we were looking at what was happening. And there was a steep increase in mortality from 2016 to 2024 for the entire population, which to us signaled this is not necessarily a change in who the program was serving, but a change in the community, a drug supply change in the community that was driving mortality. And the other thing this graph shows, again, can't see it too well, but those light blue and orange bars started to pop up in 2022, and those are fatal overdoses caused by fentanyl and meth or just fentanyl. Again, had not seen that at all from 2016 to 2020. And then suddenly in 2023, it was driving the mortality rate in this population. So I think, again, just the data really helped put some numbers and explanations to what the providers were experiencing with residents. On the next slide, so I think the other thing we could do is just this just shows you all of the data that we were looking at. Exit reasons, understanding exactly what share of people were either passing away or exiting for reasons like just the providers were unable to contact them. They lost contact, they left their housing, they were gone for an extended period of time. Oftentimes that was due to a crisis that might have started off with a substance use and cause them to lose their housing. And we were able to really dig into what was behind not just the mortality, but the other housing exits. And this is where the partners saw an opportunity to intervene in both the mortality rate and the rising exit rates, and really identified overdose prevention, MAT services, and crisis response as the things that were needed to address some of the trends they were seeing in the data. So on the next slide, the partners put together a plan to create kind of an enhanced model. So this is, several years into the program, but now we had the data to kind of understand more what was going on, and decided to intervene on these particular two. I would say crisis response was still seen as the big need, but there was an opportunity, a funding opportunity to go forward on these two strategies: intensify drug overdose prevention and intervention, and enhance access to low barrier opioid and methamphetamine treatment. So just to briefly tell you, and the providers could give much more information on this, and are actually presenting next week if you're at the Housing First Partners Conference. But the first strategy on the next slide was to intensify drug overdose prevention and early intervention. So a large expansion in naloxone availability, making sure that everyone has it at move-in, everyone has it in their apartments, all of the staff are carrying it, making sure every building has it available in the hallways, boosting staff training around the use of both of these, both the naloxone and then other strategies for harm reduction and overdose prevention. And then on the next slide, the second strategy, to improve access to MAT services. And I think one of the most interesting things that Colorado Coalition for the Homeless is doing here is implementing a contingency management program in the supportive housing building where many of these clients live. And so that's an escalating incentive program designed to treat the stimulant use disorder where there's not currently an approved medication for such treatment. So they are doing that. They're just getting started. We've designed an implementation and outcome evaluation to understand how that goes and how it works for people. So there's the contingency management program, and then there's also an increase, added a medical coordinator position to support coordination of MAT services, and behavioral health services in general. So you can see here all that is planned. I believe the contingency management program kicked off like in March. So we don't have data or outcomes yet, but it is a 2-year evaluation, and we will be tracking both housing stability outcomes through lease violations, understanding everything from minor to major violations, and then also housing exits and housing retention. We'll also be tracking ED visits for a poisoning diagnosis and fatal overdoses that we can see in the data. So over the 2-year period, we hope to get a lot more data on how this enhanced model works for these outcomes. Oh yeah, thanks for putting the corrected slide in the chat.
No problem.
Okay.
Thank you so much, Sarah, for highlighting the work in Denver, and to all of our presenters for really grounding us in the challenges and real life strategies that communities are using to address high acuity needs in supportive housing. I think it's a great opportunity to focus on what's working in communities across the country to fill in some of these challenges. So I'm going to shift us to a panel discussion that will help us dig a little deeper into implementation lessons, trade-offs, and what the work looks like over time. So we're going to start with a few planned questions and then we're going to move to a few questions from the audience. Thank you so much for submitting questions through the Q&A function. We've done our best to kind of combine some of those that we're going to share with the presenters after our first few questions. And then following this webinar, we actually might do an FAQ. So any question that doesn't get addressed here in our panel conversation today, we'll make sure that we address in follow-up materials with you all. So to kick us off, to our panelists, thinking back when you first started this work, whether this was launching a high acuity intervention or standing up a new team or responding to the changing needs of tenants, what do you wish that you had known then that you know now? And maybe even connected to that, is there advice that you would give to providers or communities who are just getting started, especially for those that I know that this work can feel really overwhelming to see the needs in communities? So what do you wish you knew, and what advice would you share with the communities on the line today? And I'm going to start with Amy.
Hi, everyone. I've been a social worker for like a really long time. And one of the things I've learned is that positive change and stability is possible even when there seems like there's a tremendous number of barriers. Recovery is not a straightforward process, but in general, over time, there is positive motion. It's also really difficult to predict, like who's going to do better and what is the time frame for that. I learned that really when I worked in shelter, it was not always the people that I predicted would do well who did well. It was sometimes the people who had some of the most challenges, but were willing to engage with staff that did well and got into their own apartments very quickly. There have been a whole lot of questions that I've been responding to about engagement. So I'm also going to say that engagement is really like one of the most important activities. And it's not like a passive thing. It's actually like something like a skill that people need to develop. It's an intentional practice. It requires flexibility, humility, and patience. And it's something that's really important with working with these very challenging populations that we're talking about today.
Thanks, Amy, for addressing that in the chat and for sharing your advice. Any other panelists want to chime in with what they wish they knew or advice that they would share with communities as they're just getting started?
I can go. I can piggyback off Amy, because as she was talking, it really resonated with me. One of the things that I think is always start with engagement, not compliance. So I've been working in, the field for a long time. I've worked in housing, I've worked with mental health, I've worked in drug and alcohol. And I think that the underlying point, I don't know if point's the right word, but the thing that helps the most in all areas really is engagement. Engage with people, build relationships. People are going to be more willing to do things if they have a good relationship with you. And in that, then follow up. We always want to look at people as the whole person, not just the piece that we are connected to, whether it's just housing or whether it's just mental health, or if you're the SUD specialist on the team, you're just going to focus on the SUD portion. No, look at them as a whole person, connect them to other services that they need, make sure that they're seeing a primary. If employment is something that they want, connect them to employment resources, food resources. So really just engaging and seeing them as a whole person, and seeing outside of your specialty, why are you working with them, what do they need, what can help them, and then connect them with whatever it is to that'll help in those areas as well.
Thank you, Maria. Others? Yeah, go ahead, Noah.
Yeah, wholeheartedly agree with both Amy and Maria on that. So just emphasizing those points, agree totally. And then one thing, just kind of from a different direction, is just a real, I think, encouragement to do some good kind of stakeholdering, to use a goofy term maybe, of like who is impacted by these sorts of issues. And often I feel like PSH providers, we just kind of take it on and try to plow ahead ourselves. And if we step back and try to engage broader systems and other, peers in the field at a minimum, but other systems that our folks are engaging with around where the gaps are, and then try to work more in one voice to try to create systems change. It's pretty impressive of the stuff we can do and do fairly quickly. And so it's not always possible, but it's definitely not possible if that stakeholder and kind of assessment of who's impacted by these concerns and these issues isn't done at the beginning. And we'll just encourage groups to do that before diving in and running solo.
Yeah, go ahead, Adam.
Yeah, I had two points, and Noah, that was one of them. It was like I wrote down like look for partners that benefit from your intervention, and so you can find, we've had examples of working with managed care organizations or working with hospitals or working with other primary care to try to just make the intervention more efficient and supportive for our population. And in like like Noah, you said, like sometimes it just feels like it's all on us and we have to put it on our backs and we have to do it. And so that was the other thing. The other thing is, if you believe in something, find a way to start it, even in a small way. Like we didn't have a chance to fully do a deep dive on the incentive program on the that we had, but we had this idea and we funded it for a small cohort of people, and so we put the money behind it, and then we it wasn't able to be like peer reviewed or anything, but we had the findings, and then we submitted it for funding, and now we are expanding it beyond the initial pilot, and it's funded, and we're doing it with Jefferson Hospital, and they're going to have it peer reviewed. And so like if you have an idea and you think it's effective, find a way to start it on a small scale, and then you can scale it from there.
That's so great, Adam. Thanks for encouraging people to start small, and to both of you for your point about systems engagement. I feel like as supportive housing providers, we often think like we have to do it all on our own and we have to build something to serve our folks, and thinking about how we help people to access systems that are intended to help our folks is such a great point. One of the other themes that I think that comes up a lot in this work is that acuity is not static, right? And that people move in and out of periods of higher or lower needs. So I'm curious to you all how you work dynamically with individuals as their needs are changing over time. Does anyone want to hop in and address that first?
I can start if you want. Well, one of the things that we do in our scatter site supportive housing is we do regular reassessments. So we're not just looking at needs, but we're also looking at like readiness, whether they're ready to go to some other kind of treatment or employment, or even for increased independence. And that allows the staff to shift between like more intensive support and then more autonomy. Like for instance, when we have a new tenant just moved in, we're going to give them like more home visits. It could be weekly or bi-weekly. And then as we see somebody becoming more stable, we're going to make that less often. And then as somebody might become, less stable, we're going to increase the amount of visits. But all that's what we're talking about, sort of stresses the staff. So the more visits, the more time on the staff, and the more difficult we have actually meeting those needs. But I think consistency is important. So even if someone like disengages, what we're talking about, just continuing to maintain a steady, like non-judgmental presence so that you can like re-engage when the person's ready.
Thanks, Amy. Maria, I saw you come off mute. Did you have something to add there?
Yeah, I think me and Amy are like soul sisters because it was a lot of that. Just really, just if one more thing to add, I guess, to that is treating the care plan as a living document. Everybody is different. Things change, whether it's the substance use changes or the drug supply changing, whether it's their housing risk level changes from at risk to non at risk. You have to, everybody has care plans or goal plans or whatever your organization calls it. And don't be afraid. I know some of them, like, you got to update this every 3 months, some are every 6 months. Don't be afraid to update it sooner. If life changes for that individual, update it sooner. You don't have to wait until, you're at the time when, when the new plan is due. And just keep reassessing and keep offering options. So, yeah.
Thanks, Maria. In our last minute, I want to take a minute to ask Sarah a question from an evaluation perspective. So when you're thinking about the work in Denver or other initiatives you're evaluating across the country, what do you think providers need to really focus in on tracking to prove that what they're doing is working?
Yeah. Well, I think there's two thoughts here. There's knowing if it's working, and then there's proving that it's working. And I think the knowing if it's working is a lot of the tracking, especially what's happening to people who it's not working for. And so understanding people who are coming in and leaving, why they're leaving, when they're leaving, what's happening to them after leaving, that's a really big part of understanding how to mid-course correct and adjust the model. And then I think the other important piece, which several of the speakers have talked about, is understanding what's changing in the community that may be affecting your program. And so, for example, the introduction of fentanyl in the community just really changed the profile of need and the types of services that providers were trying to offer. And if you're not understanding what's happening outside the program, you might think that's a failure of the program, or there's something weird going on with the people that are being referred to your program, but it's really not. It's a change in what we would consider the system or the service as usual. And so looking outside your program to understand what those trends are looking like in the community can help you better adjust as well.
Thanks so much, Sarah. And thank you all for sharing your time, your work, and everything you do for our communities across the country. We just deeply appreciate you all so much. I'm going to transition us to a quick overview by CSH's training center. So a lot of what we talked about today are things that CSH provides training on. And so I'm going to turn it over to my colleague, Ariana, just to highlight a few opportunities through CSH's training center before we end today.
Thanks, Katie. Thanks, everyone. Hi, Ariana Saunders. I use she, her pronouns again, and happy to talk to you a little bit about the training center at CSH. We provide live webinar trainings online as well as self-paced trainings, and it's fully comprehensive. We provide trainings both for supervisors and people who are doing direct service in support of housing and human services, as well as those working in property management. So on your screen, you see just a couple that highlight some of the courses that we offer. I'm just going to emphasize the first one, which is our new Case Ready Case Management program, specifically designed for folks that are doing case management services in supportive housing. And so a lot of what was discussed today, we cover in that course. It's a very comprehensive series, and so want to just highlight that. But you can see we do offer stuff around hoarding, assertive engagement, dealing with folks or understanding mental health and mental health challenges that folks may be facing, a lot of which was covered today. So reach out to us, go to our website. You can filter through and look at a bunch of our other trainings. And before I turn it back over to Janice, just want to do one little shameless plug that if folks are interested in supervisor training in person, we are doing an in-person training in Houston towards the end of this month in a couple weeks. So please reach out if you have any questions about that, and looking forward to seeing you on a future webinar. Thanks.
Great. Thanks everyone for your time today. Just a few other notes. We have the 2-pager if you want to learn more that was shared in the chat before, but I think someone will drop another link too. If you want to discuss how we can assist your community with training, consulting, technical assistance, you can reach us at consulting@csh.org. And then we have the National Center for Housing and Health. You can sign up for updates on the next slide. for our newsletter there. And then last, just wanted to share that we have a High Acuity webinar attendee survey. It's the same link that you would have gotten if you attended the first one or through the registration there. So same survey, but if you have not done it yet, we would love if you could fill that out. There's a chance to put more information in if you'd like to tell us about exciting work that's happening in your community and have us reach out to you about that. So please just take a moment to fill that out. Thank you so much for your time, for all our presenters and everyone who's been a part of this two-part series with us. We're excited to be able to share all of this and to do some more as we continue the work going forward. Thank you all for your time.
Thanks everyone for joining.
Thank you all.